Hi, my name's Tim Pawlik, and I am a professor of surgery at Ohio State. We're really happy and honored that our paper entitled Fragmentation of Practice, the Adverse Effect of Surgeons Moving Around, was recognized by Surgery as one of its best articles. This is a manuscript that looks at the impact of fragmentation of medical practices across hospitals on patients' outcomes. Whether surgical team familiarity is associated with improved postoperative outcomes largely remains unknown. So in this paper, we sought to characterize the impact of fragmented surgical practice on the likelihood that a patient would experience a textbook outcome. And a textbook outcome is a recently popularized composite measure of outcomes in the postoperative setting that represents an ideal postoperative outcome. And in particular, a textbook outcome represents those patients who did not have any postoperative complication, did not have any extended length of stay, did not have a 90-day readmission, and did not die within 90 days of surgery. In this study, we looked at Medicare beneficiaries who were age 65 years older who underwent elective surgery, either AAA repair, a CABG, cholecystectomy, colectomy, or lung resection. And then we looked at outcomes after those operations relative to the rate of fragmented practice. And the rate of fragmented practice was assessed at the surgeon level, and it was created to represent the consistency of the hospital level environment which the surgeon operated. In particular, the fragmented practice variable was calculated based on the total number of surgical procedures of interest that was performed over the 5-year study period, divided by the number of different hospitals which the surgeon operated. And then, as noted, we used the rate of fragmented practice relative to the incidence of textbook outcome to see if these two were associated. And to do this, we use unsupervised machine learning, a K-medians cluster technique to categorize surgeons into low, average, above average, high fragmented practice surgeons, and then examined outcomes. So it was a relatively large study with over 500,000 Medicare beneficiaries who underwent one of those 5 operations of interest. Not surprisingly, because it was a Medicare data set, the median age was 74 years, and about 60% of patients were male. Machine learning identified 3 specific cutoffs to categorize the overall rate of fragmented practice, and that was about 3%, 6%, and 11%. Interestingly, the majority of surgical procedures were performed by surgeons who had a low rate of fragmented practice. Only about 2% of procedures were performed by high fragmented practice surgeons, and about 8% of procedures were done by surgeons who fell into the above average category of having a fragmented practice. So a multivariable analysis after controlling for patient demographic factors and procedure type, as well as individual surgeon volume, as well as a random effect for hospitals in the model. What we noted was that patients who underwent a surgical procedure by a high versus low fragmented practice surgeon had a lower odds to achieve a postoperative textbook. And in particular, those patients who underwent an operation by a surgeon who had a practice that was characterized by being highly fragmented had an increased odds of perioperative complications, an extended length of stay, 90-day readmission, and 90-day mortality. So these findings were somewhat interesting and demonstrated that patients who underwent a surgical procedure with a high rate of fragmented practice had a lower odds of achieving a kind of an optimal or textbook outcome in the perioperative setting. And these data would therefore suggest that, fragmentation of care and fragmentation of surgical practice is another important metric relative to quality of surgical outcomes. And most likely, the fragmentation of the surgical practice is associated with the surgical team's familiarity with one another, and that in those settings where there is high fragmentation of practice and likely lower team familiarity, there were worse outcomes. So therefore, in turn, surgical team familiarity and also attempts to decrease the fragmentation of care across multiple hospitals in which surgeons are operating may be a modifiable mechanism to improve surgical outcomes. So once again, I'd like to thank Surgery for recognizing our paper as a best paper. And I'd really like to recognize my co-authors on this paper, and in particular, Madison Heyer, who was the biostatistician, did the majority of the analytic work and conceptualized this project. So once again, thank you.